Hello, and thank you for joining us for our session on doublet and triplet therapies for advanced prostate cancer. My name is Jeremy Patch. Again, I'm the Senior Director of Patient Programs and Education at ZERO Prostate Cancer. I am excited for you to hear from our esteemed featured speaker, Dr. Neal Shore, who will be joining us shortly. Now, please join me in welcoming Dr. Neal Shore. He's a urologist at the Atlantic Urology Clinics, and he serves as the medical director for the Carolina Urologic Research Center. He's out of Myrtle Beach, North Carolina, where we wish we were today, probably. Dr. Shore, thank you for joining us. It's my pleasure to hand it over to you.
Well, thanks so much, Jeremy. Great to see you. And it was great. We just had a wonderful multidisciplinary CME program at ASCO just a couple of days ago that ZERO sponsored. So thank you so much. It was really always great to talk to colleagues both at that meeting in person and virtually and talk about the most up-to-date things. It was really geared towards physicians, medical oncologists, urologists, and radiation oncologists. I think today I was asked by the team here at ZERO, which, by the way, kudos to them. They do an amazing job of really providing trusted, reliable, authentic literature so that patients and their families can get through this very challenging process. And it's true for prostate cancer. It's really true for all cancers, but the complexity of oncology now, it's really wonderful that you can go to a trusted site like ZERO and get really great information about approved therapies, clinical trials, caregiver support as well. So I'm very happy to give this presentation. I was asked to talk about doublet and triplet therapies for prostate cancer, and it's because the world has changed quite a bit. Trying to advance, but seemingly stuck. There we go. Well, go back. Now it's working. Great. So doublet and triplet therapies for high-risk locally advanced prostate cancer. What does that mean? So I'm going to talk about some concepts and really I hope I put it in words that you as non-physicians can really interpret. That's my goal here. High-risk localized advanced prostate cancer, locally advanced, has a different kind of a meaning to it. It typically means you have a high Gleason score, which makes you, you have a Gleason 8, 9, or 10, which is the more aggressive cancer. That's the high risk localized. And your disease by conventional imaging, and we say conventional imaging, we mean CT scans and regular bone scans. There's no disease outside the prostate. Now, a lot of that's been kind of turned on its ear because we have these more sensitive scans called PET scanners, and they have different tracers, gallium, fluorinated or 18F, coppers being investigated. The PET scans might show suggestion of disease outside the prostate when conventional imaging, CT scans and bone scans are negative. But we know that patients with high biopsy scores, high Gleason scores, 8, 9, 10s, high PSAs, or suspicious palpable digital rectal exams, these are the high-risk localized patients. And you see 4 studies listed here. And I'm going to go through them very quickly, but they're important because NZERAD, Atlas, and Dasl-hicap are radiation studies, and that's the EBRT you're seeing there. They're radiation plus lowering the male hormone, that's androgen deprivation therapy. And then the interesting thing in these studies is you're adding approved androgen receptor pathway inhibitors in more advanced disease like enzalutamide, apalutamide, and darolutamide. The Proteus We've completed that study, over 2,500 patients. These were patients who were getting apalutamide and an androgen deprivation therapy before prostatectomy, not radiation, but having their prostates removed, and getting 6 months of treatment afterwards. So we call before treatment neoadjuvant, after a treatment, whether it's surgery, prostate removal, or radiation, we call that adjuvant therapy. And I'll get into a little more detail on these two studies below called Embark and Aranote in a minute. Don't forget about the busyness of this slide, but this is the Proteus study. This is 2,500 patients and who have high risk localized disease. And everybody, if you look at that middle box, everybody goes to radical prostatectomy with pelvic node dissection. All the patients will get 6 months of testosterone lowering. Half of the group, the blue box, they'll also get apalutamide. And the notion here is if you can combine blocking the androgen receptor and lowering the testosterone, will that make the final pathology when we remove the prostate, will it have a better outcome afterwards to try and create cure? Because many patients with high risk localized disease, whether they get surgery or radiation, studies would say 20 to 40% will not be cured. And that's a very upsetting thing. Patient goes into surgery or radiation and they are expecting to be cured. So this study and the next ones I'm going to show you in the radiation patients is designed to try to augment our cure rates. That's really the bottom line on this study and the next few I'm going to show you. Here's the Atlas study. Now, full disclosure, I'm on the steering committee in a trial site for the Proteus. That was the earlier slide I just showed you. And I'm also on for this study called Atlas. And again, do not try to read all the data on this slide. You can if you want to, but the take home is you're a patient with high risk localized prostate cancer and you're going to undergo radiation. The traditional standard of care today is radiation of the prostate and maybe the pelvic lymph nodes and 2 years of androgen deprivation therapy, so lowering the male hormone. The question is, what happens if we add an androgen receptor pathway inhibitor? The androgen receptor is the key receptor on the prostate cancer cell that testosterone and its metabolites interact with, that turn on the receptor. It goes into the cell and causes cell proliferation. Well, if we get rid of the fuel, the testosterone and its metabolite, dihydrotestosterone, that's what turns on the androgen receptor. That's one way to shut down cellular proliferation. But what if we also block the receptor itself? I refer to that as the sort of 1-2 punch. Or if you want to stop a car from moving, one way is take your foot off the gas. That's lower the testosterone. And then put your foot on the brake. That's blocking the androgen receptor. And that's what the AR pathway inhibitor drugs do, like enzalutamide, apalutamide, darolutamide, and abiraterone. So this is a very similar study to the Atlas study I just showed you. It's called Dasl-hicap, and it's using darolutamide instead of apalutamide. 2 years of androgen deprivation therapy, patients getting radiation. Now note that this study has fully accrued. The Atlas study has fully accrued. The Proteus study has fully accrued. These are phase 3 studies, which means that they're prospective. They're moving forward. We're not looking at older data. They're global. So they have good geographic diversity, a lot of different patient populations. And also, if the results are successful, meaning that the therapeutic or the treatment arm, in this case, darolutamide, 600 milligrams twice a day, ADT for 2 years with radiation of the prostate, if it beats, the numbers are better, the patients meet the primary endpoint. And then this one, it's what's called MFS, which is a combination of radiographic progression and survival. If it beats the orange box, which is just the ADT and the radiation. I am cautiously optimistic that this study will be positive, as will Atlas, and I'm really hopeful that Proteus will as well. So there's another trial called the Enzarad, very similar to the Dasl-hicap and Atlas, but it's using enzalutamide. So now this is a study that I'm proud to just tell you about. I was the co-PI on this. It's already read out, and this is called the Embark study. And what we did in this study, basically over 1,100 patients, is patients who had surgery or radiation for high-risk localized disease, but they had PSA recurrence, basically signaling to you, teaching us that they weren't cured. And when we look at the rate of rise of the PSA over time, that really matters. So these were patients who had doubling times the PSADT of less than or equal to 9 months. Data teaches us that if you're way north of that, 15, 18, 22 months doubling time, you can just watch those patients. They don't need anything. So we took the enriched population that was more likely to develop metastatic disease on conventional imaging, not the new PSMA PET, because we started the study literally 10 years ago. So we had 3 cohorts, one where they got androgen deprivation therapy and injection every 3 months. That's the leuprolide acetate. And they got the approved dose of enzalutamide that had already been approved in more advanced prostate cancer. The orange box, they got a placebo and lowering of the male hormone every 3 months. And then the third one, the kind of a lighter blue, they didn't get anything to lower their testosterone. They just got 4 pills that enzalutamide that block the androgen receptor pathway. If patients got PSAs, the green box, less than 0.2, they got holidays. They could stop therapy. And the endpoint was MFS, or combination progression and or death. The overall survival data has not been reported yet. The MFS was largely involving just progression on imaging. That's what RPFS means. And the data was so good. When I presented this in April of 2023 at the AUA, the FDA approved it in November of 2023. They expanded the label indication for enzalutamide. So this was a really big deal. Here's the Kaplan-Meier curve, as we say. What does that mean? It basically says when you look at the combination arm, the blue at the top, versus the patients who just got the orange at the bottom, that 58% of patients were not getting metastases, were not dying, compared to the patients who got just the testosterone only lowering. The OS data, we are very, very hopeful that we will be presenting that sometime in the fall of this year. So stay tuned. Now, this is a look at, and remember, I didn't show you the curve for the enzalutamide alone without lowering male hormone, but that also beat the leuprolide and placebo arm. There's different side effects associated when you do the combination versus the enzalutamide alone versus the leuprolide alone. One of the key things when you do the enzalutamide alone, which I'm a kind of a fan of, is you don't lower the testosterone. So our experience is that a lot of these patients got less hot flashes, 22% versus much higher in the other 2 arms. And we also saw that many of these patients had improvement in their sexual desire, their libido, but they did have more issues related to breast tenderness and enlargement. But it's important to know that we didn't do anything preventatively to avoid that. And there are strategies now to combat that. So we now have, if you're a patient who has biochemical relapse, PSA relapse after your radical prostatectomy or your radiation, and your doubling time is less than or equal to 9 months. In Europe, they allow less than or equal to 12 months. You can get combination ADT, androgen deprivation therapy, and enzalutamide, or enzalutamide alone. And I've been offering the enzalutamide alone to a lot of my patients, and they're doing well. Now, there are some really kind of neat studies that are ongoing right now. Here's one of them, and it has to do with using PSMA PET scan. But I'm going to move a little forward now because of time. You know, we've just been having so many great studies that have changed us from just only lowering male hormone. That's called either, removing the testicles or giving leuprolide type drugs that go for 1 month, 3 months, 4 months, 6 months. We have some implants that you could put in for 12 months. We now have an oral drug called relagolix, which you can take daily. But one of the things we've discovered for our patients who have metastatic hormone sensitive prostate cancer is you see all these combinations here, and just doing monotherapy alone is really not adequate. But interestingly, if you look at the blue boxes, we're still seeing a third of patients in the US receiving only monotherapy. I think this is very unfortunate. There may be less than 10% of patients in my population who I see who will I'll only do that. But really, I think north of 90% of patients should receive a doublet or even a triplet. And I'm going to explain to you what that really means if you have advanced prostate cancer. Level 1 evidence means it's the best evidence we have, and it moves into all of our guidelines and agency approvals. Now, no one would expect you to memorize all the names of these trials on the left, but the point is, if you tally them up, it's about 10 or 11 so trials, the take-home message being monotherapy ADT is not the way to go. Here are the curves. We're always talking about these Kaplan-Meier curves. And really, when you see the curves overlap, that means that there's really no difference between the drug or treatment arm and your control arm. These 3 trials clearly show curve separation where the couplet or the doublet, Titan, apalutamide, and ADT, Arches, enzalutamide, and ADT, Latitude, abiraterone, and ADT, clearly bested overall survival compared to monotherapy ADT. So that's the take home of those slides. So now the next question we asked is, what about adding a chemotherapy, which has been known for a long period of time to be helpful? And this was a study done mostly in the UK, where they added to androgen deprivation therapy, that's the SOC, and abiraterone, and they then added a short course of chemotherapy known as docetaxel. And the blue beat the ADT and the docetaxel with abiraterone. So a very important first study to tell us that triplet was beneficial. And then there was a second confirmatory triplet study of darolutamide and ADT and docetaxel that beat ADT and docetaxel. And that now is also in the guidelines. Now, not everybody is a candidate for a short course of chemotherapy. You have to, recognize that there may be more adverse events or toxicities. But if you are chemo fit, you've got the right kidney function, heart function, don't have neurologic issues, you want to be more aggressive, you're more risk tolerant, as opposed to, you know what, I don't want more risk of side effects. Maybe I'm more frail. Maybe I have other comorbidities, other medical health problems. Fancy word, comorbidities. Maybe I'm on too many medications. Then maybe chemotherapy in the triplet isn't for you. But I think that the notion of having a full conversation with your team, shared decision making is really the take home point, and very important. So let's talk about Aranote. So here's the big news. This purple box, it's no longer under review. It got approved yesterday. Aranote, which looked at combining ADT and darolutamide without the chemotherapy versus ADT and placebo, was a successful trial. We reported it at a European meeting in the fall. We published in the Journal of Clinical Oncology. We've had presentations at AUA in 2025 in Las Vegas, and then this week in Chicago at ASCO. And yesterday, the FDA now expanded the indication for darolutamide 600 milligrams twice a day. So we have this kind of proverbial embarrassment of riches, whether you have a lot of tumor burden or low tumor burden. But if you have metastatic disease, like President Biden, like some patients who get it when they're first diagnosed, or they get metastatic disease later on after their surgery or radiation, you now have a true opportunity to discuss 4 different doublet therapies: androgen deprivation therapy and abiraterone, or androgen deprivation therapy and apalutamide, or versus enzalutamide, and now darolutamide. So we've made really great advances for our patients, and I think it's really super exciting. And this is just looking at whether you had high volume or low volume disease. So here's another way to just sort of think about, well, do I get the doublet or do I add the chemotherapy? And that's called the triplet. And there's going to be some more toxicity, as you see. There's more involvement, you know, it's an intravenous or infusional treatment as opposed to the doublets, which could be all orals. A lot of the ADT has traditionally been an injection, intramuscular or sub-Q, but there's now an oral version there too. So I think choice is important. So let me stop with that, and I'm happy to answer some questions in the final 5 minutes. Thank you very much.
You did it. You got through it. I didn't think you would. So Dr. Shore, thank you so much for that great presentation. Really informative. Thank you for, hitting on the recent approval of new indication for darolutamide. I think that's really important. And I want to highlight, if you can, again, because you're going through it and you've got the slides and it's a lot of information, but I want to just take some time to go over when you were discussing monotherapy and the number of patients that are unfortunately still prescribed monotherapy. Can you just walk us through that again and what the standard of care is for hormone sensitive patients, castration resistant patients, and so forth?
Yeah, it was in the 1940s where these 2 pioneering physicians, Huggins and Hodges, figured out for men who had very advanced prostate cancer, they recognized that there may be a connection to the hormone levels, specifically testosterone and the estrogen compounds from it. And then in the 80s, we figured out a way to give injections in the muscle or in the skin that could lower the male hormone without having to remove the testicles, which is, a very kind of, psychologically morbid thing to do. And then we didn't have anything that added to that at all until 2017. Isn't that amazing? 1966, Huggins and Hodges get a Nobel Prize. So for 75 years, that's all we did. And then we did trials that showed that by adding chemotherapy versus not, but doing the lowering of the male hormone, patients lived longer. And then we added these other androgen receptor pathway inhibitors, abiraterone, enzalutamide, apalutamide, now darolutamide, approved yesterday. And we now have the best evidence we could possibly have with 1,000+ patient studies conducted over the world showing that if you do the combination, the doublet treatment or the triplet, you slow down disease progression, you slow down the conversion to developing resistant disease, and you improve survival across the board. And the fact that we still have in the US about 30% of physicians just only doing the monotherapy, it's been debated. There's a lot of different explanations. Well, they see the PSA go down and they say good enough. Well, it's not good enough because we did these studies and patients will do better by adding in another therapy of the ones I've all talked about. Now, there's no free lunch, right? Anytime you add something, there's going to be some side effects. And of course, accessibility, particularly in the form of getting it covered, is important. But if reimbursement's not an issue and the side effects are not bothersome or even noticeable, doublet and triplet are clearly superior to just getting a drug that only lowers your testosterone level. And if your goal is to, avoid disease progression and to live longer, it's kind of a no-brainer, frankly.
Okay. Thank you for that. I think that's really important to cover. So appreciate you going through that again. Could you comment on whether doublet therapy should be considered in case of recurrent oligometastatic HSPC?
Great question. The answer is absolutely. We talk about when you get diagnosed right out of the gate, we use the word, sometimes we'll say that's de novo, from anew, as opposed to getting metastatic disease, years after you maybe had your prostate removed or had radiation. We call that recurrent. Overseas, they like to call de novo or the newly diagnosed synchronous, and they call the recurrent metachronous. I hate it and it's so troubling when if you think patients get confused, there's a lot of my colleagues who get confused with all this different verbiage, but that's why I would just try to explain that. So if you end up getting metastatic disease and you previously had a prostatectomy or radiation or prostatectomy and salvage radiation, absolutely, you are a very strong candidate. Now, interestingly, those patients actually do a little bit better than those who are diagnosed upfront as a general rule.
Okay. Thank you so much. Oh, were you going to say?
Well, it's a great topic because in the oligometastatic, oligo, Greek for few, and it's like, is it 1 or is it up to 5? Most people would say oligo few, 1 to 5. A lot of studies are going on now to try and delay the use of androgen deprivation therapy. So radiation to these sites and maybe some other systemic agents, radiopharmaceuticals. There's a whole big area of drugs called antibody drug conjugates. It's very exciting from a patient standpoint to recognize that we're going to continue to see the top level data can be reported at almost every new international congress. And the key ones to keep your eyes on or your ears open for are ASCO, which we just had, ESMO, the European Society of Medical Oncology, in October. And it meets every year, just like ASCO meets every year in the spring. And then AUA also meets in the spring, the American Urologic Association, and also ASCO GU, which is usually in February, late January. This is the typical place where large phase 3 data gets presented, and it'll give you the patients who are really following this literature an opportunity to say, oh, wow, this was a successful study. Will it be powerful enough that the agencies, typically the FDA and the European Medical Authority, approve these drugs or an imaging test or a biomarker?
Thank you for walking us through that. Really appreciate you taking the questions and for your great presentation. To our audience, we're so glad you could join us for this important discussion.